So before we dive in, I just wanted to highlight this gentleman, Cesar Boeck. He was a Norwegian dermatologist, kind of fitting. He's actually the founder or discoverer of sarcoid many years ago, as you can see. And it came to his attention based on many patients who were coming to him with skin lesions, as many of you may have. And through his insight, he was able to kind of conclude that this was not a malignant condition, albeit very bothersome and troubling, as we've kind of highlighted today. So skin or cutaneous sarcoid, this is the second most common organ involved behind the lung, of course, and affects about anywhere from 25 to 35% of patients. Lesions are really variable, which is why it can be challenging for providers to recognize this. I think that's kind of a recurring theme that we're hearing throughout the presentation today. Interestingly, it can also appear in scars and tattoos, so something for providers and patients to both be aware of. And given the variability of the presentation, it can sometimes resolve before you even see a doctor, or can unfortunately be permanent and associated with its own scarring, developing of pitting, or paling of areas of the skin. Before we kind of dive into the skin lesion specific, I wanted to just kind of help us frame our mindset. So when we're talking about these things, we're going to group things that are less than a centimeter in size. We're going to term those papules or macules. You may hear your providers use those terms or see that in some of the literature that you're reading. And then anything that's greater than a centimeter, we're going to term a plaque. And we're going to kind of walk through these individually as we move forward today. So papules, those are going to be lesions which are raised in appearance in how you can feel them, whereas macules are flat. They can be disseminated, meaning kind of all around the body, or concentrated to a particular area. And as I mentioned, they can occur in sites of prior injury or scar, whether it be a tattoo, a prior skin piercing, or a bruised elbow that you had from your football playing days or something of that nature. We tend to think of these type of skin lesions as having a good prognosis, meaning that on average, the systemic disease of sarcoid, meaning involving other organs, probably will occur and will kind of have resolved within a 2-year time period. Now that, by no means, I'm not guaranteeing that, but I'm just saying in general, these are kind of how we may think of these lesions. And that they hopefully also would not lead to any permanent scarring. Now before we get to that, let's kind of view some images here. The first one labeled A, you can see this is an individual's back, and you can see some kind of areas of discoloration there. And then in figure B, that's a patient's elbow, and you can kind of envision that those areas are a bit raised in size and very small, kind of smaller than an eraser head. So kind of contrast that to plaques, which these are a bit more indicative of a more chronic course of disease. And there's a higher likelihood that should they even go away, that they may also recur as well. And typically lasting anywhere from 2 years or longer. Again, kind of as opposed to the things that we tend to think might self-resolve. And these are unfortunately more likely to lead to a scar or any areas of kind of discoloration of the skin, kind of long term. Here's an example of that. Kind of a reddish purple discoloration, larger than a centimeter, as we spoke about, and would be kind of raised if you could rub your hand across that. Can also affect the digits themselves, so it doesn't just have to affect the skin surfaces, but you can get swelling and discoloration on the fingers, as shown here, which can, obviously be alarming to the patient, as well as make it difficult to kind of perform, every household day activities. Next, I want to speak about a topic that you may have heard kind of thrown around, and this is a term called Lupus Perino. This is a specific kind of skin condition that occurs specifically within sarcoid itself, so I figured it was worth spending a bit of time talking about this. This is characterized as a chronic rash that's kind of red to violet in nature, and always really characteristically just affects the cheeks and the nose, and unfortunately is thought to be destructive in nature. I'll kind of defer to my other colleagues who they may kind of speak about the sinus and nasal involvement, but it can typically do that. And it's thought to have a pretty aggressive course, or can, as well as to be somewhat treatment resistant. When providers see this type of rash, they need to be also aware and thinking of other type of manifestations of sarcoid, which would be more common, and those are seen on the right-hand side. So bone cysts, which may lead to pain that otherwise is not really well understood or recognized, because we don't go around just taking x-rays of people's bones all the time. Pulmonary fibrosis, or scarring of the lung. Uveitis, which we'll get into a little bit later in this talk, but that's inflammation in the eye, as well as then arthritis. Now I want to contrast this to something called the lupus malar rash, or the butterfly rash. And this is characteristic of a whole different disease known as lupus. You may know or have heard about this in the community. This type of rash and disease is totally separate from that which we're talking about here, but I highlight it only because they share that common name, and that's mainly based upon just the origin of where the rash appears. So Lupus Perino, so what does that look like? So as shown here in the top left corner, it kind of red to purple in color and kind of affects the cheeks and the nose, as I had mentioned. You can see that it's kind of caused some swelling, or there's what we would say maybe a boggy nature to the nose, and you can lose some of the kind of margins there. And then on the right, a more dramatic presentation, which is this kind of bulbous growth coming out of the nose, which is all associated with Lupus Perino. On to kind of scar and tattoo involvement. So it's important for patients and providers alike to be aware that when examining patients, especially those who have just suspected sarcoid, I imagine most, if not all here, are either a caregiver or actually have the diagnosis, so this may be a little bit behind you, but for providers to recognize that when looking for possible involvement, that it can involve these areas. As shown in the picture there on the right, you can kind of see some nodularity that's appearing in an otherwise normal-looking tattoo. Again, it's kind of this red to purple discoloration. Even though that may be on your mind, in all honesty, these are pretty subtle findings, and they can mimic other things such as keloids or hypertrophic scars. So that appearance alone would not be diagnostic, but at least would maybe raise one's suspicion and plan to do some further workup. Their association with a chronic course, or clinical course, is kind of unclear. Some literature would suggest that if it's involving these particular areas, that the patient's course is going to be pretty self-resolving, while others tend to think that it's a sign that sarcoid is going to be around for a while. I think that's probably speaks more to anything that we just don't know enough and we haven't looked at enough patients yet. This is just to highlight that simply finding a granuloma, we've kind of talked about what that is and what that means, and that's really needed in order to make the diagnosis of sarcoid. Should you find a granuloma in a tattoo, meaning somebody biopsies your tattoo or scar and finds that alone is not enough evidence to make a diagnosis of sarcoid. We still need to find other areas of systemic inflammation that would be characteristic of the disease. On to a syndrome called Löfgren Syndrome. This is a particular syndrome within sarcoid affecting the skin, and it kind of presents with this triad of clinical findings. Acute in nature, meaning it lasts on the order of days to weeks, oftentimes associated with a high fever, and then on chest imaging it's going to have something called hyolymphadenopathy, or swelling of the lymph nodes that are in the middle of the chest. And typically patients will present with stage 1 imaging, meaning that the swelling is just contained within the lymph nodes. It's not spread out to the chest any further in the lungs. They'll also characteristically have some reddening of the shins, termed erythema nodosum, as well as arthritis. Looking at a couple images of this, it's shown here in the chest x-ray. You can see kind of with our arrows. Unfortunately, the patients don't come with arrows like that. But under the right eyes and the right suspicion, you would say, wow, that looks like that shouldn't be there. And that's that swollen lymph nodes that we're talking about, and that you've probably heard your doctors talk to you about as well. And then the reddening of the shins is termed that erythema nodosum. Now, of course, both of these clinical features can exist outside of this syndrome and are characteristic of sarcoid. But in the clinical context with this in combination with a fever and acute onset, that may kind of lead you to a specific subdiagnosis within sarcoid. The presentation, I think, is kind of interesting in that, so here in the United States, when we kind of look back retrospectively, patients who present with sarcoid and are found to have this termed Löfgren Syndrome, we think it's about less than 1% of the time. So I would venture to say if we had time to do a poll today, there wouldn't be too many hands being raised for that. They have similar findings there in Great Britain. But then just not too far away in Scandinavian countries, as well as in Spain, about 30 to 50% of patients who are presenting to their clinic are presenting with these features. I can't tell you why that is. I'm not sure we have an answer. I think it gets back to kind of these genes we're talking about and the interplay. Sure, the environment could also be affecting it as well, but you kind of wonder because Scandinavia seems to be so heavily affected and Great Britain's not too far from there. So I'm not sure if environment alone is really the explainer, and it may be more genes and heritage, but this is just kind of all theorizing. So diagnosis and treatment. So what do we do specifically for Löfgren syndrome? The actual diagnosis or the actual treatment of sarcoid, I'll defer to one of my colleagues, Dr. Rackley, but this is just specifically for Löfgren syndrome itself. And important to recognize that in this situation, a clinician, we really shouldn't be pursuing any kind of biopsy. We know that if we were to biopsy that reddening of the skin on the shins, it's going to be a non-diagnostic study, meaning we're not going to see those granulomas that we would expect to see. We're going to see septal paniculitis, which is just kind of a non-specific finding of inflammation. And it's oftentimes self-resolving. So treatment is relatively benign for the fever and the joint pain. Simple over-the-counter things like ibuprofen or Motrin would be reasonable. And then should that get more extreme, you and your provider can talk about other medications listed here. Now kind of shifting gears onto ocular or eye sarcoid. So this affects not as common as skin, but certainly something to be aware of in at least about 20 to 25% of patients overall. But for whatever reason, kind of similar to what Dr. Houston had alluded to with cardiac sarcoid, those of Japanese heritage, they seem to have a much higher prevalence of sarcoid involving the eye, upwards of almost 80%. And in general can be the presenting symptom in about a fifth of patients who eventually go on to a diagnosis of sarcoid. Sarcoid can affect any part of the eye, from the lacrimal gland that makes tears all the way to the back of the eye, all the way to the optic nerve, like Dr. Moss had spoke about earlier today. But uveitis, meaning a specific inflammation, is the most common, and we'll kind of unpack that term together here for the time that we have left and kind of talk more about that. So this is just kind of a caricature of the eye itself, and uveitis we're going to split up into two groups, anterior being most on the leftward side of the screen, and then posterior being kind of everything behind the lens affecting the back of the eye that the doctor is going to look at. Anterior uveitis, these are going to be symptoms that patients are going to complain of or report, I should say, that are going to say my eye is painful. It's oftentimes going to be red. The pupil, you may note, will be constricted and might notice some actual vision loss in that eye as compared to the other. Not exclusive, but more commonly this type of manifestation is seen in those who are younger, who are African American, and who are female. And in visual examination of the eye, it's thought to be that you can see this kind of cloudy anterior chamber. That's what's kind of shown here on the right-hand side, where there's these kind of deposits, and those are white blood cells that essentially shouldn't be there. They should be in other parts of the body, but they shouldn't be in that front part of your eye, and that's what's leading to some of these symptoms. Contrast that to posterior uveitis. Now we're kind of in the back behind the lens, and this is instead going to be more painless, but it's going to be associated again with vision loss. And you may notice, or patients may report, symptoms of floaters, or kind of seeing things in the corners of your visual field that you know shouldn't be there. I'm seeing some head nods there. And characteristically not associated, even finger pointing, okay. And characteristically not red, but of course that doesn't exclude it. And again, kind of as a general rule, but not as a hard and tight, fast one, is that this is more commonly going to be seen in patients who are Caucasian and elderly, and again in females. Shown here on the right is an image of kind of the back of the eye. You can see all these white spots that maybe look like snowballs. Those should not be there. That's abnormal, and those are kind of termed these punched out lesions that your eye doctor is looking for when he's taking a look in the back of your eye. So because of this, all patients with sarcoid, there's really 3 things they should get on their annual exam every year when they see their eye doctor. And this is recommended for not just patients who have known eye involvement, but patients just in general. If you have a diagnosis of sarcoid, you should be seeing your eye doctor at least once a year. And that's the slit lamp exam, a fundoscopy exam, which is a fancy way to say we're looking in the back of the eye, or a tonometric exam, which is where they're going to measure the pressure. So let's kind of look at what those may look like, and then you'll say, oh gosh, yeah, I've had those before. So there in the upper left, that's the slit lamp exam. That's going to allow a physician to look really deeply at all the chambers in the eye and get a much better look than they can on the right, which is the fundoscopy exam, where I'm sure is the doctor and patient's favorite, where we're getting very close to your face. You're smelling the tuna fish that they had to eat for lunch that day. And they're getting a look at your optic nerve and all the vessels coming out of the optic disc. Then this pen here is this way to measure the pressure on your eye. Now that's not the only way. I don't want people to say, well, they've never come at me with that pen, so they're not checking it. You can check it through other ways. Some of the other way is commonly where you're looking at this like balloon, and then all of a sudden this puff of air hits you in the eye. Another really pleasant way to spend your afternoon. But important for the reasons we talked about. This is a feature that ophthalmologists know well that is very classic and characteristic of sarcoid in the eye. There are many features in general that can support a diagnosis of sarcoid involving the eye, but this one in particular, termed these candle wax drippings, or these kind of white areas that are kind of creeping and crawling along the veins of the eye, would be pathognomonic, or in other words would mean, almost a slam dunk for sarcoid. Otherwise, typically, to arrive at a diagnosis that sarcoid is involving the eye, it typically would involve that you would already have a diagnosis of sarcoid, and then we're seeing characteristic features, and collectively your eye doctor and your other doctors, and then putting that clinical picture together. But by that reason, you can imagine that sometimes it's hard, and you can be diagnosed with other eye problems, and then your diagnosis of sarcoid comes later. And that's because oftentimes we're not advocating that any kind of biopsy or sample or tissue be taken from the eye for obvious reasons. Then lastly, so uveitis itself, as I kind of alluded to, this can precede your diagnosis of sarcoid or other systemic inflammation by even up to a year. So again, I think important to kind of piggyback on what had been said earlier, it's very important that you all stay informed with your own health and what's going on, and be the best advocate for yourself. If you're having new eye problems, or you're hearing about other, friends and family in the community, not that sarcoid is going to be the most likely thing that's causing that, but it should be something maybe to keep in mind. And also important to know that eye involvement doesn't really dictate one way or the other whether that disease is going to be severe or not. Patients can have very severe disease and their eyes are never affected, or patients can have just eye disease and it be very severe. So it doesn't seem to tell us one way or another, but it's certainly something that we want to, no pun intended, keep an eye on.